I've defined difficult airways as a typical situation in which conventionally trained anesthesia provider experiences difficulty with mask ventilation, difficulty with intubation or both. And we are going to talk of who is conventionally trained, because as we know, most of us pick our practices from others, we read, and there are times we know what we have been taught or what we have read, and we pick our own ways of doing things. Now, one of the issues that we need to be aware of is when to interrupt your intubation. When do you stop? When do you say, I cannot continue trying to intubate? And today, when we were just introducing ourselves with the sponsors, they told me of a story of a patient who was intubated, or attempts were done for a whole hour with 3 experts. Everybody else has wanted to help, and they said, we know how to intubate. Give us time, we are going to intubate you. And for a whole hour, the patient was being intubated. You know the results. Epoxy death. And from there is when the Society of Difficult Airway was born. And most of what we discuss that we know is from checklist. Pilots cannot just take off on an aeroplane without having a checklist. And I don't know how many of us in our normal practice have a checklist of knowing this is what I'm going to do in case B happens, or in case Z happens, am I prepared? So if you make an attempt to intubate and it is more than 30 seconds, please stop and start oxygenating your patient. Don't go beyond 30 seconds. You would rather give your patient oxygen and think what you are going to do. If you find that your patient is becoming cyanosed, and this normally happens when you are not well prepared, you don't have a plan, and therefore you have not pre-oxygenated your patient, and within 30 seconds your patient is cyanosed, stop. If on the monitor you realize that arrhythmias are developing, stop. And when you find that you have got hypoxia. So these are things that can tell you you need to replan, you need to rethink, and when you are rethinking, how do you oxygenate your patient? Now, there are several factors that contribute to difficult airway. Some are to do with the provider himself or herself. The others have to do with equipment. And most of the time, you might find that whatever you put to use is not available, or you had not looked for it, or it is malfunctioning. Many times you have tried to open your laryngoscope, and you find that the bulb is missing because you are not prepared. You didn't know you had not prepared your equipment before. There are times you find that it is too dim, or it has no batteries, and you have already anesthetized your patient, paralyzed your patient, and the best you can do is to panic. Then we have got patients factors, and we will go through each one of them. Now, provider factors depend on your experience, and this is where the training comes in and your experience. Sometimes we sabotage ourselves, or we are sabotaged by the people who want to assist us. If you look at the 2 pictures below there, I have experienced that when a patient is put on the table with a pillow, the first thing we do is to remove the pillow. I don't know whether you have that experience. You are already sabotaging yourself. Whoever removes the pillow for you is actually sabotaging you. And you convert a very easy airway into a very difficult airway just by removing the pillow. The other one is inadequate preparation, especially preoperative assessment. I still think, and I have heard, there are still many of our providers who meet their patients in theater. You have not assessed your patient, You don't know what is wrong with your patient. You just come, you want to anesthetize. Sometimes you have just been told anesthesia A is not available, and you come and help. So instead of you assessing your patient and seeing how your patient is, you just go dive in, give you a propofol, give you a tractorium, then you realize, my God, I cannot be able to intubate. So provider preparation and patient's preparation is very important. The other one is poor technique. And I have shown you when you have a patient who has a neutral head, or a patient where you decide to place something under the shoulders instead of under the occiput, you're already using a poor technique. The idea is place a pillow or place something on the occiput, under the occiput, and the pinna should be above your sternum or the sternal notch. You find that you not struggle. If you remove, at least you have an experience, you are going to struggle trying to intubate your patient. Patient factors could be congenital. We have Robin syndrome, whereby you have got developed, you have got a very big tongue and cleft palate. Again, when you try to intubate your patient, you find that the breath goes into the palate and you cannot be able to expose your vocal cords well. Then we have Peter Collins syndrome, whereby the main feature is mandibular hypoplasia. Therefore, you have a very big tongue relatively, and you cannot be able to intubate your patient. Then we have Goldhand syndrome, whereby again you have got hypoplastic mandible, and then you find that the atlas is connected to the occiput, so that you cannot be able to move, you cannot be able to extend your head. And if you had not examined this patient and you are just doing routine work, you can imagine how difficult it can be. Then you have Down syndrome, where again, the main problem is the big tongue, macroprosia. Again, if you're not well prepared and with the proper equipment, it becomes a very difficult intubation. Then we have Klippel-Feil syndrome, where again, you have fusion of the cervix or cervical vertebrae, and therefore there's no movement at all of your neck. You cannot flex, you cannot turn your neck, you cannot extend, and it gives you a very difficult intubating situation. Then we have the acquired patient factors. Could be infection. Supraglottitis gives you a angioedema, the same with croup. And what normally happens is that the size of the tube you are expecting to use, or the area where you are expecting to put your tube, you find has been interfered with because of edema. Then you have arthritis, and this could affect either your temporomandibular joints, whereby you end up with temporomandibular joint atherosclerosis, and therefore you cannot be able to open your mouth at all, or it could affect your cervical spine, whereby you cannot be able to move your neck. You cannot be able to flex, you cannot be able to extend, and it will give you problems. Then there is trauma, which can distort your airway, or you can have hematomas. Then there are tumors that can either distort the airway or they can have structures fixed, especially when we are talking of a tumor, CA of the larynx. You find that it is fixed to the adjacent structures, and therefore flexibility of intubating becomes a problem. Obesity, it might not be a very big problem for us, but it is real, and it can actually be a cause of difficult airway because of the thick neck. Then you have burns, which could be acute burns, and this is mainly edema, or it could be old burns giving you neck contractures. So When you go to assess your patient and you are actually assessing the airway, what are the aims or the objectives? You want to see whether you can be able to ventilate your patient using a mask. That is the main thing. Even before you think of intubating your patient, the first thing you want to know is, are you comfortable doing a mask bag ventilation? The other one is, if you are unable to, are you able to insert a supraglottic device? This is LMA, this is a nasopharyngeal airway, or this is an oropharyngeal airway. The other one, aim is, are you able to do a tracheal intubation, direct laryngoscopy? And the third is, are you able to do a front neck surgical airway in case you need? And you find that there are some people like the ones with fixed necks, you might not even be able to do a tracheostomy on these patients. Now, that's a diagram that summarizes the few things that you assess of your patient. So if you start with the temporomandibular, this is the element of distance. The green one tells you you are okay. There is no high risk of you being able to encounter difficult airway. And it goes all the way to the red, where it tells you if you find a patient with temporomandibular distance that is this short, you are going to encounter difficulty in intubation. Then you have mouth opening, whereby we look at the distance between the incisors, the lower and the upper incisors to see. This you allow the patient to be able to put their 3 fingers to see whether they can be able to accommodate. If you are not able to accommodate even 1 finger, again, you should be prepared for disaster. Then you have neck extension, whereby you talk of more than 30 degrees, whereby you can be able to extend your neck very well. If you cannot be able to extend for more than 10 degrees, means disaster is waiting. Then there is the upper lip bite, whereby you are supposed to be able to bite your upper lip above this area has a name. I can only demonstrate. And then it tells you you are able to move your temporomandibular joint. Then we have the Maran party. Everything that anybody who has done the airway assessment of Maran party, we have from Maran part class 1, where you can be able to see the tonsillar pillars, up to Maran part 4, where you can only see the heart palate. Sometimes you can see nothing. So Maran party, other than out, you are also supposed to assess how much you can be able to see when your mouth is open. Tell you whether you are going to have difficulties in inserting an endotracheal tube or even inserting a supraglottic airway. Then we have got the grading of the laryngeo, what you see when you put a laryngoscopy. Then you have from grade 1, whereby once you insert your laryngoscope, you can be able to see your vocal cords very well, up to grade 4, whereby you can see nothing when you do your laryngoscopy. So these are the few things when you're assessing your patient, you are able to look into and see whether they can predict whether you are going to have a difficult airway or not. When you have a combination of 1 or 2 of them, it tells you that your work is going to be quite difficult. And the importance of which we cannot overstress is the importance of reviewing your patients. Now, these are the congenital issues we have gone through. This is the first one is the Robin syndrome. If you don't assess your patient previously before you take them to theater, you will not be able to know how they look like until you get them in the ward, in the theater. This is a child with Peter Collins. This one has both hands syndrome, and you can see the defects and the poor development of the mandible and support. And then these are a nightmare, whereby you have a patient who has no neck at all. I don't know of our experiences, but that this would make you collapse when you think of how to access the airway. Now, still on patient assessment, again, these are several pictures. If you look at this patient, when the mouth is closed, you think that this is a patient you can be able to hold a mask very well, ventilate. You can even think that you are going to be able to insert a supraglottic airway, but immediately you tell them to open the mouth, this is what you are going to see. And this now changes your plan completely. And this again overemphasizes why you need to assess your patients. Do the simple thing, just tell your patient, open your mouth. There's so many things you're going to be able to see, which you could not have seen. Now, this is a patient with an obvious mask, so you'll be able to have a plan when they are predictable, difficult anyway, anticipated one, so you'll be able to plan from the one go. This girl with contractures, again, you cannot be able to access the front airway. You cannot be able to do a tracheostomy because the contractures are such that the lower jaw is connected to the sternum. So you have to think of how you are going to access that airway. Now, this is a patient bilateral cleft lip. Again, you might be able to hold on a mask, but the issues might be, are you able to do a tracheostomy, a laryngoscopy without dislodging the hanging bits? That is the teeth that are in the hanging. Again, we have this. When the mouth is closed, he looks quite well. You might think that he's going to be able to be ventilated well, will be able to be intubated well. But when you tell the patient to open the mouth, the first thing you see is a bleeding tumor, and you can actually see nothing when you are doing your party assessment. So this tells you how important it is for airway assessment as you are assessing other facilities or other faculties of your patient. Now, this plan has been developed. We have been allowed to use it. It is developed by the Difficult Airway Society of Great Britain. It has been adopted by most of the societies in the world that deal with difficult airway, and it has 4 plans. And this is made for patients you find that they have no previous issues with their airway. So you are going with your plan A, that you'll be able to anesthetize your patient, paralyze your patient, do a laryngoscopy, succeed, and then continue with your operation. That is plan A. And most of us always go to theater with our plan. We don't even give it a name. We call it our plan of anesthetizing. Now, plan B is when you try to intubate your patient, you find after attempts, 30 seconds are over, you attempt again, and we are out to do up to 10 minutes of interrupted attempts until you say after 10 minutes that we are done. We are not able to intubate. So you go to plan B, and this is mainly where we insert our supraglottic devices. Again, there are many. We have now got very many types of radio masks. They are going to be demonstrated to us. We have nasopharyngeal airways and we have oropharyngeal airways. The only thing you need to know is that when you're inserting those, your patient has to be well anesthetized, otherwise you are going to compromise your airway more because of fighting. The only one that can be able to accommodate is a nasopharyngeal airway. Otherwise, an oropharyngeal airway or a LMA can be a problem if your patient is fighting. Now, if you are able now to succeed, you have to think, stop and think. Do I need to continue with this operation? Or do we need to look for help? Do we need to do this surgery later? And a few of us have made those decisions that this doesn't have to continue. We don't have the proper equipment for us to continue. It's not an emergency. We can work well with up the patient and we can plan. Or you can decide to use the LMA to intubate. Again, we will be demonstrated to us that there are some intubating LMAs that you can be able to use just to slide your tube through the LMA. Or you decide that you are going to do a tracheostomy or tracheotomy. Now, if you fail to insert, if you feel your patient cannot be able to accommodate and you're not articulating your patient, you go to plan C, whereby again you remove all the devices you have tried to insert and try to hold your mask again. And this time you try to call other people to help you. You can do what we call two people mask and ventilation. So you as the provider hold the mask while somebody else is trying to push the bag to see whether you are able to ventilate your patient. And the idea is to provide oxygen. This time now, the issue of intubating is not an issue. The issue is to make sure that you don't end up with hypoxic brain damage. If you succeed, you wake up the patient. You are allowed to wake up the patient and plan. Either refer to a center where it can be done, or decide, are we going to do regional anesthesia, or if it was general anesthesia that was necessary, what else can be done? You are better off with an awake patient than with a hypoxic patient. Then the option D is whereby you cannot be able to intubate your patient and you cannot be able to give oxygen. Can't intubate, can't oxygenate. It is a very scary situation. I don't know how many of us have been able to be faced with such. I would hate to be in that position. Whereby now you have to do a front neck access of the airway. We are afraid of blood, you are not prepared, you don't have the equipment, and it can be a disaster. So this has been developed as the pathway to deal with airway issues that you have not anticipated. When you have anticipated your airway difficulty, then you are able to accept your equipment and you can be able to plan. So what equipment plan and which you should have from your kitchen? Now, a few of us have tried to assemble a few things. Sometimes you don't get the help. Sometimes you keep things leaving because of many users. You find that using a McCoy and laryngoscope. The following day, you find that it is not functioning. Somebody has interfered with the sprint. Sometimes you have a video laryngoscope. The following day, you find that somebody has screamed it in spirit, and therefore the screen is functional, not functional. But as we advance, we need to have airway kitting that can be able to deal with difficult airway. Rigid laryngoscopes of various sizes and shapes, the McCoys, the mirrors, we have the B-shaped. Again, those are laryngoscopes that we can be able to have for us for difficult airway. The tracheal tubes. Again, the habit of just having only one size of a tube, you have calculated your size, that this is a child who is 10 years, I'm going to use size 6. Then you find by the time you're going to intubate, the laryngeal opening is so small, you need a size 5, and it was nowhere. You might panic. So it is always good to have various sizes and different sizes of the tracheal tubes. Bougies, guys, the McGill forceps. McGill forceps has saved us a lot. It helps you to twist your tube and be directed into the larynx. LMAs, both intubating and normal ones. If you are comfortable, you should have a retro intubating kit. This is whereby you introduce a puncture through the firing, and then you can be able to thread either a wire or an iron size one through the mouth, and you can actually be able to pull your tube. You should have anterior neck access kit. You should also be able to have a non-invasive airway ventilating devices, and a nabo bag, which we call a nabo bag or a self-inflating bag, is a must. Actually, in every theater, again, it has saved many patients. You need to have a carbon dioxide end-tidal monitor or device that can be able to detect and tell you you're in the right place. Most of the time, just by seeing the expansion, you might not know whether it is the abdomen, the stomach that is in the chest that is expanding. So you need to at least have a CO2 detector so that you know and you are certain that you're in the airway. Video laryngoscopes, the spelling, and bronchoscopes, fiber optic, both the bronchoscopes and the laryngoscopes. Again, the people who are marketed to us, they sell us the bronchoscopes. It is so cumbersome to use a bronchoscope when we have an emergency. I wish we could be able to have the short laryngoscopes, which are easier to use and they are more direct. Because using a very long instrument when you're in difficulties can be an issue. This is how you arrange your difficult airway drawing. It should have all the equipment that you need for plan A, for plan B, for plan C, and for plan D. And once you open, these are the few things you might find, like a coil and laryngoscope, and many other gadgets that we are going to be shown today. We can decide whether we are going to buy a few so that we can develop our own kitting. Now, a month ago, I encountered a child, a 10-year-old female, 25 kilos, with a temporomandibular joint and paralysis as the diagnosis. And the issue was that the child had fallen from a height, from a decker, and had hurt the mandible, but they never thought there was a fracture. So they just treated the child conservatively. And then after some time, the child could not eat. The father noticed and the mother noticed that the child was not enjoying eating. When they consulted the doctor who assessed the maxillofacial surgeon, found that the child could not open the mouth, and with X-rays, they realized that the child had developed temporomandibular joint and paralysis of the right side. So the child was booked for resection with grafting, whereby you graft from the cartilage of the lip. And when I assessed the child, there was zero mouth opening. The other systems were okay. And from the word go, we knew that this was going to be a difficult intubation. Now, the issue was the hospital where we were doing it, we could access a fiber optic, and the bronchoscope that was available could not accommodate a tube of size 6. So we had to go to plan Z of doing blind nasal intubation. It is somewhere. We might not find it in the APCD, but in this side of the world, whereby you might find that we don't have of equipment or they're not accessible, we use the oldest method that has been used for blind nasal intubation. And this is what we did. And it was a 2-tube technique, whereby you put one tube through the nose just to maintain oxygenation and sedation, and you use the other nose for you to insert your tube. And this time I used the neutral neck. I did not want to place a pillow because we inflate the tube cuff for you to be able to direct the tube upwards. When you inflate the cuff, you are able to inflate and then lift the epiglottis as you direct the tube into the radio opening. And It was a successful intubation. I think it took shorter than we have tried to use a fiber optic laryngoscope, and the patient was successfully operated on. So these are the two tubes. You push one of the tubes up to the esophageal opening, just at the level of the opening of the larynx, and you maintain your sedation because you don't want your child to wake up when you are doing the process. Neither do you want the child to get hypoxic. So you are comfortable. Even if you don't succeed, you know your child is breathing very well. We don't paralyze our patient, just keeping them deep with I was using as a fluorine. Then through this other tube, again, you push it up to the laryngeal opening, and then give a bit of liquid spray so that you can be able to anesthetize the vocal cords. And once they are anesthetized, you can sleep in your tube. And this is one way we have found is cost effective. You just need to run the method, and it is actually cost free. The only cost actually was an extra endotracheal tube, nothing else. And we were able to open up the child. So I rest my presentation there. If there are any questions or any contributions, I'm happy to answer. Thank you.
Thank you. When you start one, it is the same for two of the 30-second arrhythmia, the cyanosis, or the desaturation of the cord. It is whichever comes first. And are we actually following this 30 seconds, or what's your suggestion for us?
I think the first stage is even pre-oxygenated your patient very well. So most likely they're not going to develop cyanosis or even arrhythmias within the 30 seconds. So that is why 30 seconds is number one. If you find that within half a minute you're not able to put in your tube, just stop. If you find that cyanosis has developed within the first 2 seconds, stop. Means you cannot prepare your patient well. Yes. And it is both for children and for adults.
Another question for Willie with size 2 PTT intubation. How does one confirm the trachea not the esophagus if no capnograph is available? And if esophageal intubation, how do you correct to make it trachea? I think she represents some of us who are in the rural setup. Yeah.
She has started with the size 2. How do you know whether you are in the esophagus or in the trachea? If you don't have a capnograph, most of us actually don't have. What do we go for? We go for your saturation and your arrhythmia staging, your cyanosis. So it is more clinical. It takes a bit of time, but you still be able to know you are not in the right place, because if you are saturating at 100%, then it goes down to 80, you know you are not in the right place. And when you suspect, because all of us actually have intubated through the esophagus. I can assure you, even on Saturday, I did. It is knowing you are there and coming out. The issue is actually the crime is not to intubate the esophagus. The crime is not to know or to argue that you're in the right place. That is where we have our issues. And it happens a lot, especially when you are teaching.
That I think Dr. Willie, you can answer the question: how do you correct esophageal intubation? I think he's made it very clear. You take the tube out, you bring it again, you think, then attempt. So Henry Ogonyo says those of us who are watching through the virtual sound is much better. I hope it's clear right now. Dr. Bernard Kenemo is asking, how do you deal with tank fall and obstructing airway with use of bisulfurate?
It's a difficult question because is it an induction? Because again, when you're prepared and the tank falls, you know you have to use your devices. Now, what we did go through, which would have made maybe our discussion quite tedious, are the maneuvers you know when you're using your airway. You have the chin lift and the head tilt. You have your jaw thrust, which you can actually do as you wait for somebody to bring you your airway or the esophageal airway. But you should be prepared with all your gadgets when you are going in, such that at your time you actually even give you a problem, even in the absence of bisulfurate. So long as your patient is sedated or your patient is asleep.
There's another question from Edwin Umani. He says, thank you, Dr. Kabetu, for your presentation. What do you think the high flow nasocannula could be an option in maintaining oxygenation in difficult airway travel?
High flow cannula actually can maintain oxygen, but again, you need to know how are you redirecting it, because most of the times you might find that the issue is access, either the tank has blocked your airway, so you have to have optimum in terms of airway exposure for even the cannula to be able to work, because what you need is to have your oxygen delivered.
Wondering, nowadays we still have
I think something, how do I put it? When we used to do a lot of tracheostomies for non-definitive airway, we had problems of where to take our patients. And we lost very many patients because of taking them to general wards, whereby the care that is supposed to be given is not available. So we try to reserve our tracheostomies for patients who will require definitive airway. Now, part of the preparation is alerting surgeon and ENT surgeon, telling them we are having this case, we might request you to come on condition that you're going to reverse the tracheostomy before discharging the patient from theater.
I hope that is well answered. Okay. A question from Chocolate.
Thank you, Dr. Ali, for distance care, distance education, what you what portions. Thank you, Dr. Ali. We need to complete the story. You have successfully intubated people. How do you go about intubating your patient? And again, the same assessment that you've done, you plan, where do I take this patient? Now, you have seen most of the patients whereby your definitive airway is going to be a tracheostomy. They are definitely going to go to either ICU or they are going to go to high dependency unit. The problem comes with those patients, you have succeeded, the mouth is open, like the TMJ, and then when do you decide you're going to extubate them? The safest is when they are fully awake. And in fact, I allow my patients to pull out their tubes. And I don't leave the theater until they have been discharged to the wards. You don't leave your patient in the recovery ward to wait for you to be called 10 minutes down the line when you're in the thick of traffic that airway has been compromised. And in most of the centers now where we work, we have a PACU as no limit in time of discharge. So the time of discharge is actually the provider. So if you want to be successful in dealing with difficult airways, difficult anesthesia, the human being is very important. Be available till your patient has been discharged. It's the only thing I can be able to tell you, Dr. Chokwe. Otherwise, there is no other criteria of knowing where to extubate, where to take my patient to ICU. There are those ones you have taken long, and we electively take them to ICU with a tracheotomy tube, and we extubate them after 24 hours, after 48 hours, but they have actually to extubate themselves for you to be able to be comfortable.
Thank you for that. There's Rose. She's asking, she says, thank you for the good presentation. Can you do a case study in a journal on this? Or am I the only one who has learned about this today? I have few maybe difficult situations. All right, I don't know if it's a video. You're planning.
Yeah. You talk with me. So I think this is where some people said complain they were not seeing what we are demonstrating here. So this was just demonstrating about the patient that is on the screen, and we employed two tubes. One tube to continue oxygenating the patient and sedating the patient, and the other one for intubating. And you insert your tube to be at the level of the laryngeal opening, and the way you measure your distance is from the tip of the nose to the trigas or the tip of the ear. The pinna, it is the same distance from the nose to the laryngeal opening. So one tube, you leave it there so that you can be able to sedate your patient, continue sedating and giving oxygen. And you can take as long as you want, so long as your patient is being sedated. The other tube, you insert the same, following the same measurement. And so when it is in the lungs, you spray with Rignocaine to be able to anesthetize the vocal cords. And then what I was saying is that when the tube is at the nasopharynx, if you inflate the cuff, I hope you can be able to see, you find that when the cuff is inflated, the tip of the tube is redirected upwards. And you can actually be able now to push the tube into the laryngeal opening. And you can also see the inflated balloon is able to lift the glottis so that your laryngeal opening is available for the tube to be able to be inserted. So you push in your tube while listening to the breath sounds until you meet resistance, and this will be at the level of the vocal cords. Then you deflate your tube as you insert, and then once you are sure you are inside, you inflate the tube again, and you can test whether your tube there is resistance to your pulling of the tube to know that the tube now has gone, the cuff has gone beyond the vocal cords, and you can actually be able now to ascertain by inflating and also by checking your capnograph to know that you are in the trachea.
I think that is clear now. From Idris Mohammed says, thank you, Dr. Kabetu, for the presentation. Can we have the slides and the photos? I think that will be made available on the same website. Minimum, is there an option of using a stylet to direct the tube outwards?
Our sponsors have come with a rated stylet. So your answer will be, your question is going to be answered, and it is actually, it has a camera at the tip, and it can be used to redirect the tube upwards to enter into the trachea.
From Ahmed Kenemo, he is asking, how do you listen for breath sounds with stethoscope? I don't understand this question. Maybe you can clarify them. From Kaiser, he says, thank you, Dr. Kabetu, excellent presentation. Mwani says next talk. Susan Omudi says, thank you, Dr. Kabetu. Any questions from the audience in the hall? I think the demonstration was clear to Henry Ogonyo now. I think then at this juncture, I'd like to invite, first of all, let's give Dr. Kabetu a round of applause. Presentation. I think everyone has learned something today. We are here to learn more. So I think at this juncture, I'll invite sponsors today from MIG. I think I'll invite Charles, then so we introduce his team and take over. I think I would like to make a few announcements so that we can run those on the program, the sponsors today. So there are a few announcements from CSA. First one is the conference. Driving Paradise, Shansi, Mombasa. More details, you can find them on the KSA website. And they're also open for people who have us. Maybe you can send them to Shelby as well. The other thing is KSA membership fee. I know most of us have not paid, maybe due to Corona or any other reasons. So you are reminded to make sure you are up to date with your membership fee. The other announcement is also we are welcoming suggestions for CMEs. Any suggestion, any topics you like to be discussed. So kindly also get in touch. You can send an email to Shelby through our official email. There's another All Africa Anesthesia Congress, which will be in Kigali, Rwanda, from the 7th to the 10th. So for those interested, you can plan to attend. And finally, this is a call to everyone. We are looking for volunteers as KSA to support and also mentor the anesthesia trainees with the GAT training. I think the group of anesthesia in training. So anyone who's willing, who's ready to volunteer, Dr. Shiko, we can make a good coordinator. So yeah, please, we need your help. Thank you. Thank you. I think I'll invite Charles and he'll take over. Thank you.
So I hope you are all having a good time. And let me introduce Flexicare and MIG-Kenya. So first of all, let me say Flexicare. Let's say that Flexicare is the manufacturer of the airway products that we distribute here in Kenya, and we have a comprehensive range for airway devices, that is anesthesia, critical care, oxygen therapy, and also aerosol therapy. So we have a table in there. You can come and have a look at our products. If you have any questions or inquiries, get in touch with us. So now that the conversation is over today, let me do that. Now I'll start with the Flexicare team. And we have two visitors from the UK, and we have Mr. Ahmed Fadala. So he is the area manager for Africa markets. And then we have Mr. Julian Long. He's the product manager from Flexicare UK, and he's a presenter for today. And then onto the MIG team, we have our managing director,
Dr. Mustafa Talat. We have managers, starting with Mrs. Mary Warenge. She's our sales manager. Then we have Mrs. Stella Atino. She's a product manager. And then we have Ms. Charity Maninda behind there. Yeah, so she's a product specialist, and I'm Charles Nana, medical representative. Now I'd like to introduce our speaker today, Mr. Vivian Long, so that he can take you through this presentation. I hope you'll enjoy it. Mr. Vivian.
So thank you for having me today. It's a pleasure to present in front of you. And it's interesting that some questions came up from the previous talk, which was a great talk, by the way, Dr. Kabetu, on certain scenarios. So what I want to talk to you today about ProView video stylet. But first, I just want to introduce you and give you a little bit of background about Flexicare themselves. So we were over 45 years of manufacturing expertise. We were set up in the early 80s by an anesthetist, Dr. Kabetu, who was a bit of an entrepreneur as well. So saw a business opportunity, and we started selling rubber tubing into NHS in England, and throughout the years then we've expanded portfolio and our reach globally as well. So much so we came from the humble beginnings of a factory in Wales in the United Kingdom, and now we actually sell and have main distributors and main offices in over 120 countries around the world, such as Australia, Europe, USA, and so on. So, and we have different offices. So we have the Middle East, we have offices in Jordan, and Ahmed works closely with the guys in the Jordan, and Ahmed is responsible for the business in Africa, and we work with a great team MIG distribute our products. So as you can see, we've got quite a global reach. We're still a privately owned company. We're still owned by %. So we have an incredible amount of flexibility in the way we can actually produce our products. We produce, manufacture, we design all our products in-house. So we have that expertise all in-house, and have a number of top-class manufacturing facilities over the world as well, so that we can be secure in supply. As you can see, we've grown a lot since the rubber tubing. We basically have pretty much everything that you would need, from urology to oxygen and aerosol therapy to breathing systems, anesthesia components, and where the products that I'm in charge of. So I'm the product manager for the airway management products that we're presenting to you today. So we have a wide range of airway management products, and as you can probably see from this list, we can pretty much, mention the airway pulley. We pretty much supply everything that you need in a typical airway trolley. So it's a really wide range quality airway management products. So that's just a little bit of background into Flexicare itself, but what I want to talk to you about really is our video stylet. Now, I'm probably going to be repeating myself or repeating the doctor there on his presentation, so we'll probably move through these slides quite easily. So basically, what is a typical airway? So it's somebody who's skilled in airway management, experiences difficulty when using one or more different techniques. Now, you guys are trained to assess these patients before use, and there are various algorithms which show you the Plan A, Plan B, the Difficult Airway Society algorithm that you can then put in place to deal with that anticipated difficult airway. That's an anticipated difficult airway. In very rare circumstances, there are unexpected difficulties as well, even though you do the due diligence and due care. So why does that happen? So there are many different factors, such as the operator experience, patient type, they have any comorbidities, lifestyle factors, asthma or smokers, and so on. Also, there is equipment has a lot to do with it, which is one of the main reasons why I'm talking to you today. The ability to see the vocal cords with an automatic format plane grading system. And we've already touched upon with esophageal intubation. Again, you know, it's a very common thing that will happen, and the failure is not intubating the stomach, it's recognizing that you've intubated the stomach. The video stylet will show you that you're intubating the stomach straight away. So it's, again, through a variety of reasons, anatomical and both physiological. So the anatomical went dead then, involves challenges foot and or passing the tube into the trachea, or if there are physiological factors, the incident of adverse events such as hypoxia, anemia, hemodynamic response, and I just noticed I've got cardiac arrest, the spelling mistake, cardiac arrest, sorry, arrest. So it causes all these sorts of complications. You're all familiar with this. And the worst one at the bottom is it can cause death. So it's quite a serious thing that you need to be able to try and manage. So we're an equipment manufacturer. So this is why we're talking to you about different things. So what I want to talk to you about is the equipment that you use for difficult intubations. Now there are lots of technology that's improving, constantly improving these days, and there are lots of different devices out there that can be used for difficult airways and difficult situations, such as video laryngoscopes, stylets, malleable or articulating stylet or bougies, and bronchoscopes. So these are all great products, but there's no one real device out there that is designed for a difficult airway. These are all sort of different techniques that you adapted to use to try and cope with airway. So I just want to go into a little bit more information about these devices. So video laryngoscopy is meant to give you a better chance of intubating your patient in a difficult scenario. And where that happens, you don't have to align your oropharyngeal and laryngeal axis. So this allows you to be able to get a great view of the actual airway itself, even when the ability of that difficult airway gives you that great view, but you've still got to get the tube there. So it should also require less force, less trauma, and better tolerance. But in reality, the laryngoscope, as good as it is for difficult airways, it still has some disadvantages. So as I said, even though you don't have to align those axes, you still have to manipulate the ET tube. Probably you have to use a stylet to shape the ET tube, and that's guesswork. Then you insert the tube in, doesn't quite fit, the shape isn't matching anatomically, so you have to take the device out, reshape the stylet, reinsert it, and also can cause potentially trauma to the patient's tissues when you're not actually put it in place. The patient is slowly having hypoxia in front of you. Another issue with video laryngoscopy is that when you do actually use the video laryngoscope, you insert the ET tube. So if you see the top picture there, gives you a great view of where to go. And at the last crucial second, the actual tube blocks the view of where you're actually going. So you're essentially doing a blind technique with a video prop. So at that crucial stage, when you need to see exactly where you are and where you're going, video laryngoscope will get obscured by the tube. So a device that shows you where it is at all times would be a fantastic device. So the other main standard that we touch upon through difficult airways and through anticipated difficult airways is what we call the bronch. Now, again, this is another technique or another instrument that is designed for something else, and it's a technique that has been adapted to try and deal with difficult airways. It's not its primary function. And there are some difficulties with the actual fibroscope intubation. So one of them is that when you actually to get the actual tube, get the scope into place, you get a great view of the breathing into the trachea. We've still got a railroad, the ET tube, down the actual scope itself. So again, you're doing video technique, you're doing it blind. And often some of the complications you see with that is that you have difficulty in passing the ET tube with the larynx, it impinges on the epiglottis, it's stuck on the tissues. And some have even recommended that to try and stop this, that you actually use a smaller endotracheal tube on the fibroscope so that it doesn't stick out as much, but then you're reducing the amount and the volume of air that you can use on that patient. So it's not ideal. The setup for these with the bronchoscopes, and assuming you're all more than familiar with these, but it is time consuming. I think it takes on average about 10 minutes from start to finish to set bronchoscope up. So if you get that unanticipated airway, then pretty much that's not the product for you, because you need something that you will be able to hands on it straight away, switch it on and use it. So it's not really used or recommended for non-anticipated difficult airway. Due to the length of the bronchoscope as well, it's a two-person job. So you're taking two people out of the actual theatre staff and so on to try and do this technique. So one is holding the actual tube and has to railroad it down. So it's very, very challenging technique. And they say that continuous practice is needed to become at least familiar with the technique of intubating via bronchoscopy. I think it's something like 10 different intubations to become proficient, and then you need to maintain that. So, you know, it's a really difficult skill to master. So what I wanted to show you more about then is ProView Video Stylet. So this is just a little teaser video. Dramatic stuff. So ProView Video Stylet. What is ProView Video Stylet? So ProView is the brand name for all of our video enabled devices, Flexicare. So what is it? It's basically preloaded endotracheal tube with a stylet. At one end of the stylet, you have a video camera and LED lights. And at the other end of the stylet itself, you have a control wheel, which allows you to be able to maneuver the tip of the device up and down. So as I said, it's a preloaded endotracheal tube and stylet. It comes with its own endotracheal tube. And the reason is because in order to get that, we need to have a different design on there. So we've got a little, what we call a concertina effect underneath the cuff. And actually, so it allows that movement. You try to use a normal endotracheal tube, using this stylet, you might get some movement, but it's really stiff, so you wouldn't be able to get the range of movement that we have. So, to all intents and purposes, it's a stylet, so you can and you can also remove that malleable. Is this better? Okay. So you can also remove that malleable rod and that stylet, so you can add extra flexibility of the tube. So if you're going to go through the nares or intubate through a laryngeal mask as part of the plan B of the difficult airway algorithm, then you can take advantage of that flexibility, but you still have the ability to maneuver the device itself. So what is it ideal for? It's ideal for oral, nasal intubation, particularly awake intubations. We've had some hospitals in London, Guy's Hospital in London, that are doing a lot of work on awake intubations, and they're using ProView Video Stylet for that now. So also, as I've already mentioned, as part of the plan B, when you cannot ventilate, cannot oxygenate, you need to look at intubating through supraglottic airway. We can also use a Berman airway to intubate through. And also this is another technique, a retromolar approach, where you have the teeth that are all clamped together. You can actually place it, straighten the tube out, place it down the side, and go right the back of the molars. So this is what we call ProView Video Stylet, and at Flexicare we sort of come up with this term of it being a direct intubation visualization technique. So it's a bit of a mouthful, but what does it mean? Direct means it's accurate, it's really quick, it's a rapid intubation, and it's an intubation device. That's the be-all and end-all. It's designed for intubation. And I've been with the guys from MIG the last 2 days, and I'm sure they're sick of me saying this at the moment, but what I want you to take home from this is that with the intubation, the image you see on the screen is exactly where the endotracheal tube is. There's no other device that offers you that. So that's what the intubation part is. Visualization, so you get that image again, and the technique. So as I mentioned, with fibroscopes, it's a 2-person technique. You can use this with a single person. You can do it very quickly, either with a laryngoscope, video laryngoscope, or without the laryngoscope. It really is that adaptable. So it's direct, so I'll go into a little bit more detail. So it has accurate placement. So you have this control wheel that maneuvers the actual tip itself. It has a 95 degree of movement, so 45 degrees extension and 50 degrees flexion. So that's more than enough for you to be able to navigate past any obstructions that you're likely to encounter. It has a 60-degree field of view, so you can see all of the anatomy that you need to. And because we have this directional control now, we're all about reducing that risk of trauma, Flexicare potential trauma. So with a normal ET tube, you have to have some sort of rigidity of that tip in order to be able to push it through different things that you need to. But because we've got that directional control, we've actually reduced the softness or reduced the hardness of this tip. So it's a really soft, malleable tip. So when it's in place, it won't cause as much damage on the tracheal wall. So you intubate it. So, your current practice is, you see the chest rise, you think you're in the right place, you listen, the breath sounds, and then finally you can use capnography to determine that you're in the right place. With video stylet, probably video stylet, and I'll keep saying it, the image that you see on the screen is exactly where the tube is. So you are now able to view exactly where the tube is. So you can immediately recognize, you can view all the way down to the carina, so you know you're in the right place. There's no accidental esophageal intubation because you can see exactly where you're going. And what it does as well, the human factors side is really relevant. And what I mean by human factors is the fact that you become fixated on doing something. And that great case is with Elaine Bromley in the UK, where there were 3 anaesthetists and they were so fixed on being able to intubate that patient that time went out of the window. And they were really fixated on this. With this, you're able to see what you're doing at all times. So you get rid of that fixation because you know exactly where it's going. Visualization, so it's the latest camera technology. Cameras are getting smaller and smaller these days, so we're able to use the best cameras to give you a really good view. And when we do the demo in a little bit, you'll be able to see the clarity of the actual camera and the screen on there. So the camera is located at the end of the stylet, and it's surrounded by 6 LED lights. So the LED lights illuminate the airway, but because they're LED lights, they don't give off any heat, so you're not at risk of denaturing any tissues. And the stylet then is actually recessed somewhat into the tube itself, so that it doesn't actually come out onto it sticks out into the tissues. So again, I say the camera is located at the distal end of the endotracheal tube, and I won't apologize, but therefore the image that you see on the screen is actually where the tube is. The technique itself, it really is quick and easy to set up. If you compare it to a bronchoscope, which takes about 10 minutes from start to finish, you can set the Probe video stylet up in about 1 to 2 minutes. So for difficult or unanticipated difficult airway, this really does lend itself to that. And it's single use, single-handed use. So you don't have to have somebody else. So if you needed that bronchoscope, you've got to get someone in there, you can operate it yourself. You can use it with or without a laryngoscope, and therefore the nature and design of the device, you'll place the tube directly where you want it to go. So again, you see exactly where the tube is at all times. And this is a product that is actually designed for difficult airway management. When we designed this product, we came up with the concept. It's because people had come to us about this and we've actually designed it for difficult airway management. No other device is designed for that. We've taken everything and tried to adapt to different techniques, but this is designed for it. So we concentrate on the adult market at the moment. So the size of endotracheal tubes that it comes with, the size is 6.5, 7, 7.5, and 8. We are going to come out with smaller cameras and smaller size tubes, but the actual design of these is somewhat further back down the line because of the actual small cameras that we're looking at. The tube itself, it's not, to all intents and purposes, it's an oral nasal tube, so it has all the markings that you will need on there. You will see the depth markings, The only difference is, as I've already explained, is underneath the cuff itself is this concertina effect that gives it the movement of the actual device. But when you inflate the cuff, that in effect then becomes a rigid tube because it's placed inside the cuff. So the cuff makes it a rigid tube, so then it won't be able to twist or block when it's in place. We've also increased the size or increased the number of Murphy's eye. So apparently we're not allowed to call them Murphy's eye when there's more than one of them. So they're ventilation eyes. But again, that's all about making sure that you're able to ventilate the patient should that tube become occluded during the procedure. So you've got two different Murphy's eye, more air can come out. And the tip makes it's a lot softer, so it's designed at reducing that risk of trauma to the patient. So this is now just another video to sort of finish with. It goes through a little bit more of what I just explained. These are all available on our YouTube website. So if you go into YouTube and type in Flexicare, we have a wide range of videos and information there that you can, on numerous products, not just ProView, but this is just the instructions to use.
Intended to assist with oral landings or activations. First, remove ProVPS from the package. Flip the cuff and check for leaks. Once satisfied, flip the cuff. Connect the camera line to the monitor directly, or use the amplifier cable if increased length is desired. An image will appear on the monitor from the ProVPS, and the camera lights will illuminate. Shape the preloaded malleable rod as needed, or remove if increased flexibility is required. Use the ProVPS's video stream on the monitor as a guide for the intubation. The directional ET tube tip allows for controlled flexion and retroflexion, enabling precise placement through the vocal port and video confirmation of the correct ET tube placement within the trachea. Once the ET tube is correctly positioned, inflate the cuff and carefully remove the video stylet portion. Then attach the ventilation equipment to the ET tube while holding it securely in place. Disconnect the video stylet from the monitor. Completely deflate the ET tube cup before extubation.
Okay, so that's ProView Video Stylet. So thank you for your time. I think, don't know how we're going to manage this, but we will be doing some demos, so you can come along while you guys in the room are actually having your dinner and just use the device and see it. But do you want me to do a demo right now on camera for the guys that are watching live? Okay. All the depth markings, the graduations, so you can correctly and accurately show the depth gauge. Has the vocal cord depth markings on there as well. Where it differs is the tube itself with that concertina can actually move out that range of movement. If you tried to use a normal endotracheal tube on that, you'll see that the movement is really not good enough. So that's the reason for that design. The tip itself again then has this soft, the extra ventilation eyes. So if I just put the stylet back into the tube, it comes as a direct connection to either an 8-inch display, or we have a smaller 3.5-inch display as well. So if it's for emergency use, you can just pick up the smaller display. We have a wrist strap, you can attach it to your wrist and use it in anger. Most of the time, we'll be using it on a larger 8-inch display, This can be pole mounted onto a drip stand. We supply the drip stands and the poles as well, so that you can view it. The articulating arm that we supply will actually allow you to maneuver it into the line of sight directly over the patient's chest. So when you come to use it, what I would suggest you use is, first of all, make sure the stylet is in there. So when you go to control it, put your thumb and your forefinger on either side of the wheel. And then you just, almost like a pincer movement, you maneuver the device. You can do it with your thumb, but it's not as receptive as that. So the easiest way you find is to hold it like this. And put your finger underneath the little blue tab. So when you guys in the room come to try it, I suggest that you just have a little go at getting used to the actual maneuverability. You can hear as well, there's a clicking noise, so it sticks in place. So we've designed that because with a fibroscope, let go of your thumb, it goes straight back to the neutral position, which sometimes is really annoying. So we designed it so that it will stay in place, but if it meets any unexpected resistance, it'll revert back to a neutral position. So again, reducing that risk of trauma. So you get used to it outside. Then when we go to insert the device, so what I would do is you hold it like this. So your normal practice with most endotracheal tubes is to hold it halfway down. You won't get the advantage of the movement. So hold it like this. You just need to displace the tongue slightly. So even if you use a tongue depressor or your thumb, so you can see on the screen there. So what I would do is I would visualize it going straight in just past the tongue. As soon as it's past the tongue, I would look at the screen. And then, as you can see on the screen there, you get an image. So what you've got to realize from this point is that the camera, again, I'm sorry for this, is right at the end of the tube. So if you're used to a video laryngoscope, the camera is slightly recessed, a little bit back. So you just got to get it in your mind that the camera is where it is. So once it's in place, you can maneuver it up and down. So there's the esophagus. So you can instantly recognize you're going into the esophagus, so you bring it back. So what you need to do, there's the vocal cords slightly anterior. So if you just pull the wheel towards yourself, turn the wheel, it brings the actual vocal cords into place. And then you can use the device to go into the trachea. And what you can do then is stay centrally using the wheel to stay centrally all the way down. And what that does then gives you that instant visualization of the carina so that you're actually in the right place. Then you hold the tube in place and just remove the tube. One of the main, another sort of advantage of this, so you know on the 18 tubes you have the 2 black lines that allows you to correctly know when you're safe enough to open, to inflate the cuff without damaging the vocal cords. You can actually view those on the way out. Probably can't see it, but you can see there's the first black line, there's the vocal cords, and then there's the next black line. So I'm probably a little bit too deep, but so you can actually view that as well. So it's another verification that you're in the right place. You're able to intubate, or you've intubated the patient fully. If you were going through the nose, as I say, what we would recommend is that you take that out so you've got the flexibility of the tube and you're still able to maneuver it. Once it's in place as well, you can almost use it like a joystick to go left and right, naturally, you should say. So you can go left naturally and you can go up and down. So it really is quite a clever device. So that's video stylet. Do we have any questions?
Any question from the audience in the hall? I think there are a few questions online. Kevin Mann is asking, how much is the video stylet in the Kenyan market?
Yes. So that's a good question. And I always leave that to guys in MIG the team, they will be able to work with you to get a competitive price. But what I will say is, when you compare it to the price of a fibroscope, the repair of fibroscopes are really, really fragile. They're not designed to withstand harsh cleaning conditions. So if you have to send it off because most of the time you have to send it off for repair, it's almost half the price of the scope just to get it repaired. And likewise with the marine scopes, more than price competitive. But yeah, I leave that to the sales guys. I'm not a sales guy. That's my head close anyway.
Another question from Winnie Wangi. She's asking, you cannot use conventional tractor tools with it.
No, that's true. And that's because of the movement. If you wanted that range of movement, then an ordinary endotracheal tube, the forces that are needed to move that range is far in exceedance of what we're capable of. So that's why we come up with the design of that concertina effect underneath the cuff. So it gives it that movement.
So a second part of the question is, and is the stylet single use or the TTs for it?
Yes, sorry, I should have said that. So the stylet itself. So this comes pre-packed. This is all a single-use device. The product that it connects to, the screen and so on, is reusable. It's a single-use device because we know that this device is going into the trachea and lots of prions and nasty sort of pipes live, if you forgive my term. And if you're using this product again on someone else, then the risk of cross-infection is really going to multiply. So we want to make this as safe as possible and use this as a single-use product.
And final part of the question. Sorry, in Africa, we always want to ask the price.
Yeah.
So she's asking, is it locally available and what cost?
So I'll let you say it is locally available. Where
she's in Nakuru.
Okay.
Kenya.
yes.
You can always get in touch with our safety company training, and they will ensure that you make that really available.
So yeah, just that. So it's available with our sales team, MIG. Just contact them, and they will be in touch.
So final one, not really finding the reviews. I think Roshni is I don't know if it's a he or she. They're asking, is it possible to organize live demonstration in hospital?
Absolutely. That's the one thing that we recommend, that when you do start to use this, we would come in and do an evaluation with you. We would like to support you in the use of this. So that's what we really pride ourselves on, is being able to support you guys when you're using it, because it's a new product. It's slightly counterintuitive to what you're used to. After about maybe 2 or 3 goes, you'll click and you'll get it. But for us to be there and support you, so again, contact the guys from MIG and they'll be more than happy to help you.
If that's it on your things, maybe we can give him a round of applause. I think Dr. Kabetu, back to you again. There are a few questions that still came through.
Yes. In the future plan of us being able to use our smartphones installed in the screen. At least we are doing that with ultrasound.
So yes, so the smart and observant ones of you will notice that there is a USB, mini USB connection. So it can connect to something that has a camera. But the thing that you will find is that the image isn't as great, because we've done a lot of work on the software of the image. So for instance, when you actually press the tube and you use the tube, there's a lot of blackout that happens on the screen. So the software has been adapted so that it minimizes all that blackout and all the shadowing effects. Also, and I've used it on a smartphone, you sort of move the tip, and then you'll see the actual, you move the tip and then the screen, and then you'll see the image move. So it does get a bit laggy, but you know, in the future, that might be something that's entirely possible. We might be able to supply like a software patch that will be able to go on a phone, but at the moment, no, you can, but you can't.
Any other question for him before we allow him to sit?
Perfect. Thank you, and thank you very much for allowing me time. In pleasure.
So to Dr. Kabetu, I can see a couple of attendees who are asking, why did you opt for isoflurane gas induction that patient? And I had Dr. Choke also whisper the same.
Why not? I think induction agents, I think the way we have been taught, you can use halogen from the maximum to minimum. When I'm using isoflurane, I graduate from 1% up. So you are able to titrate and you are able to be comfortably use isoflurane. I don't think there is any. We used to use either for induction. It is more irritating than isoflurane.
You should tell us his thoughts. The teaching, I was asking, what was the teaching at school? Which one is better between halogen and isoflurane?
Okay, I remember like halogen had less difficulty as compared to isoflurane.
So I think that's where most people are coming up when they ask their high school.
So I think one of the things is that you are comfortable with what is available. Most likely where I was, there was no halogen vaporized. So it is always good for you to be able to know what is expected and how to manage. I'm trying to imagine those of us who feel they can only induce with halogen. If you went to an environment where there's only this fluoride, what would you do? If you went to a place where there's only ether, what are you going to be able to do? So it is always good for one to be flexible with whatever is available and know the limitations and the expectations.
Thank you for that. From Dr. Mark Gashi, is asking in the DS algorithm, especially by the time we reach part C, please comment on whether we should aim to completely paralyze the patient in order to facilitate EMV oxygenation.
I think I answered that on the wall. When you are reaching stage 3, and remember you started with option A. What do you do in option A? You give your patient a sedative and you actually give your patient either a short-acting muscle relaxant or a long-acting one. So when you are reaching C, means you are actually supposed to be reversing that patient. And one of the teachings that has been there is when you have to choose your short-acting muscle relaxant and you cannot be able to use hexamethonium, you use rocuronium. And the reversal for immediate reversal for rocuronium is sugammadex, which is a very expensive agent. It is available in a few of our hospitals. So instead of thinking of adding more paralysis, when you're in stage 3, stage C, you actually at the stage of waking up your patient to decide what else do you want to do. So I would not advocate for paralyzing our patient, or if your patient was not paralyzed, don't paralyze them when you reach stage 3.
Any other questions from the audience? Before we close the chapter. Okay then, maybe we can appreciate him once again. So, final comment from Rose, she says, enjoy your dinner. And also for the people who are online, we welcome you. Still enjoy the building house. Thank you. I think there have been no any other announcements.
Also, well, yeah, have your dinner as well. If you want to come up and actually use the whatever, then feel free to do.
All right, then I think I'll welcome you guys for dinner. Dr. Kabetu and I really sponsored for it. So as much as you can want. Thank you.
Thank you.
Thank you.
Extension. Tube itself, again, it's exactly the same as an ordinary or metal tube. The only difference is underneath it, just see stuff like sort of spring-like concertina thing, and that gives it that movement. If you use it on ordinary tube, try to do that movement. There's no thing there. It just doesn't work. That's the main reason why it comes preloaded with that. The easy tube then is soft head. Pass that around, it gives you that real soft feeling. So it comes preloaded as such, so all you have to do is just take it out of the packet and it's ready to use. Just connect it to the actual screen. And with the screens themselves, what we wanted to do, this is a difficult airway device, so we didn't want you to have to toggle through different screens to press this, get the white out or something. What we wanted to do, this is an emergency, you just want to plug it in and use it. So then what we do is, you get used to the maneuverability. See if I can do it upside down. You just drop the tongue a little bit, so if you can see there, gives you that visualization. So you visualize it just going past the tongue, and you can see. So if I move the screen that way, the wheel that way, brings the wheel up, so where it goes down. So you can actually see there's the esophagus, so you know that you're not in the right place. Let's bring it back out a bit. You can go left, you can go right, so you can centralize it. So we're a bit low there, we need to be more anterior. So we just move the wheel, advance it slowly, which in past here. What we would recommend, mostly it's user preference really, is you take the stylet portion out and then use the flexibility of the device, stay all the way centrally down into, and then you get that visualization of the green there. So you know that you're in the right place. You don't have to worry about anything else. It's that peace of mind that you have. So please have a go. Who's going to be first to have a go? Perfect. If you want to go around that way, it's probably do it. So hold it in your right hand and with your much. That's it. And then you can just get used to it. If you use your thumb, you find you get one movement right, but you can't really get the movement the other way. So you just hold it like that pincer movement. Perfect. So when you go to insert it, there's this little button. See the little hole there? That line goes straight up. That's the neutral position. So visualize it just going past the tongue. Just maybe tap the tongue a little bit. Visualize it going past the tongue. And as soon as you visualize it going past the tongue, then revert to the screen. There you can see this. So you want to put it in a little more. Nice. So you can maneuver the wheel left and right. And if you advance it slowly, it's need to lubricate it. It's rubber against rubber. Yeah, just get used to it. That's it. And don't worry about being gentle with it. It's really robust. Yeah. So, I've seen people sort of do that to it and think, oh my God, I'm going to break it. So what you probably find there is going in a little bit too far because the camera is right on the tip. Just there we go. Now if you stop there, you rotate the wheel towards you. It brings it into view. Push it forward. Now if you rotate the wheel towards myself, there you are. Unless you want to, you need to make a little bit of space, or if there's space there just to get the maneuverability. But it's dependent on yourself.
Stick your finger.
Because we have a guy in the States that uses this quite often. He uses a tongue depressor. He just lifts the tongue. Something simple as that. So it's got that ratchet system, so it gives you that, that you sort of reach the next level as well.
No, not confidential because it's a new product with not set the pricing, but next week we should be ready. Next week. Yeah, so and our team is very well trained, and we will be more than happy to go and attend some more time valuation and inside of it.
And the wheels.
It has a reusable
Push
one.
the tube
Like
down.
exactly where
For the time being,
That's exactly where the
and
tip of the tube is.
our
So you look.
approval is single-use sterile product.
So push the tube down.
Maybe down
There you are. And if you turn it, push it down again.
Just making the tubes.
Turn the wheel towards me.
Then,
There you
so
are.
we have
small
the
thing
stylet.
considering.
And straight in.
Yeah. Sometimes with the money kind of gets a bit tricky.
Yeah.
Oh,
Yeah. And also we've got a video laryngoscope as well that complements this. So if you look at the actual image on that as well, this can connect to the larger screen as well. So you've got the whole system. So you can use this in conjunction with the device. It's an all metal blade. So it's designed so it withstands normal direct laryngoscopy forces, where most other devices are not designed for that. But also, because it's a metal blade, it's really thin. So it's half the actual width of any other blade. So you've still got to be able to pass the tube through, and you've got a big bulky blade in there.
I think that will save a lot of money on the laryngoscopes.
So this can be removed, the screen itself can be removed and attached to that. So this is the throwaway bit, that's the reusable bit.
Get the full benefit.
Again, instant picture, so we just want you to be able to use it.
Now, if the position is start going forward.
So you have all these available, or you'll be selling all this?
Yes,
Yes,
The
yes.
You'll be able to get a catalog for next week?
Yes.
For all
Yeah,
this?
yeah, just contact the guys in MIG.
You have the image. Well done.
Or if you want to just leave us your details today,
Okay.
and then they'll be in contact with you.
Yeah, also put the email on the website. So if you need any brochures, any quotations, so you can send to the email. You can
Our
apply.
colleague Sam is coming from the UK. I think he had a long day, so maybe that's why the plastic was a little bit.
Yeah. He's on his last legs, to be honest. No worries, thank you.
It's a pleasure.
So visualize it without looking at the screen until you get past the 10. There we go. Then we'll look at the screen. Once they're there, so you can turn it left or right, and then you rotate the wheel towards you. That will elevate it a little bit. So if you rotate the wheel towards me, it'll bring it down, push it forward.
Yes.
And then push. That's it. And then you can keep rotating the wheel as you go down, so you keep it centrally, so you don't scrape against the wheel rings.
You know, I find that female physiologists,
Okay.
they have more delicate hands. They get on board really. But
I'm
we men,
listening,
we
I'm
try our
listening.
best. We try our best. Yeah, perfect. Well done. How does it feel? Is it? Very, very straightforward, not stressing. And this is the video range scope. We have the conventional mechanism.
So yeah, that just pulls off.
I just pulled off.
Yeah, it's plug and play. Just take it out.
So let me show you. So that just, so that's the
This can be reused. No.
We say you cannot use. It's 100% metal, and lots of my customers tend to get the best output.
As
So
a-
does it come with different blades?
yes. So we have all the Mac sizes, Macintosh sizes. We also have what the Kabetu was on about with the difficult Airway blade. We have a size 3, 4, and a 3.5 as well. So
So how do you attach the blade to this?
that comes.
It comes like this.
It comes
so-
like this.
Ready to use.
So all you do is, the idea is this will be on charge.
Only
You get the
difference
blade.
is that
And also,
You can connect it either to the small 3.5-inch screen, or you can connect it to the large 8-inch screen, and both are plug
so
and
then
play.
you get the you get that into the view, and the views really. So yeah.
Thank you. It's a pleasure.